I'm used to this thing.
Okay, do whatever you
No,
want.
I
man.
probably could have used this.
Yeah, you gotta turn that on, and then this is the laser. It's green. That's how you
Oh,
know
cool.
it's legit. It costs more money. This is forward, and maybe forward, and backwards. Pretty easy to figure out. The part chair zoomed in.
I am joining this meeting. It's that cardiovascular guy from Krasicki. Oh,
That cardiovascular guy.
Probably a stupid question, but if I mute my computer, they can still hear on Zoom, right? John, can you give me a thumbs up that you can hear me?
we can hear you.
I seriously considered not responding just to, mess with you, but
All right, guys, so I went down to sit in my seat and then wait for someone to introduce Austin, and then I realized that was actually my responsibility. So, thank you guys very much for coming today. Wonderful audience out here. I'm glad we have so many people. I think we have a really special guest today who's been helping us just tremendously over the past year in terms of advancing our research capacity and what we're doing now in the Biodynamics and Human Performance Lab. So he and some of his team came here to help us with one of the projects we're working on. We had a great morning of data collection, and that was very helpful. So I present to you Dr. Austin Robinson. He is currently the director of the Neurovascular Physiology Laboratory at Auburn. He did his postdoctoral training at the University of Delaware, really doing a whole lot of neurovascular physiology. And he did his PhD at the University of Illinois, Chicago. So he's become one of the leaders in the field, and they've even talked about him giving the keynote lecture, perhaps at one of the upcoming American College of Sports Medicine conferences. So just to give you guys an idea of how lucky we are to have him here and presenting for us. So without further delay, I'll turn it over to Austin. Thanks for coming, Austin.
Thanks for that introduction, Greg. Nice to meet you all. So I'm Austin Robinson, assistant professor at Auburn University in the School of Kinesiology. And the title of the talk today is the consequences of dietary salt loading on cardiorenal function in healthy adults and racial disparities in salt sensitivity. All right, so talk outline, I'll briefly go over my background. Greg kind of touched on some of it, but I do like to share kind of my training path for those of you who are still in grad school and trying to kind of figure out where you're going to go next. We'll talk about salt and blood pressure independent effects of sodium. So we'll specifically focus on vascular function or epithelial function and kidney function. And then we'll talk about racial differences on the effects of sodium. And lastly, we'll talk about some of the future directions in the laboratory and any questions that you all may have. Okay, so I'm originally from South Bend, Indiana. I did my bachelor's degree at the University of Indianapolis in exercise science. From there, I decided I wanted to do a master's degree. So I moved on to the University of Illinois at Chicago. And then towards the end of my master's degree, started looking for PhD programs, decided I definitely wanted to do a PhD and decided to stay on there. From there, I did a postdoc at the University of Delaware for a few years with Bill Farquhar, who's an expert in autonomic regulation of blood pressure. So he assesses things like reflex sensitivity and sympathetic nerve activity and how that contributes to blood pressure. And then in 2019, I started a lab at Auburn University. This is my current team, and we have Meryl Culver, who just started with us this year and graduated here from here at Georgia Southern. And so they've been helping collect some of the data that's kind of more in the future directions slides. All right, so cardiovascular disease. Cardiovascular disease or heart disease is the leading cause of death in the United States. You can see that's greater cause of death than cancer, unintentional injuries, pulmonary disease, and then you can also see for females that stroke, which is kind of lumped into the cardiovascular and cerebrovascular diseases, that's the fourth leading cause of death for females and fifth leading cause of death for males. So major kind of public health, mortality, morbidity costs there. And then in terms from a financial cost, some of the more recent data from 2015 suggests that stroke and heart disease cost directly and indirectly about $350 billion per year. So that accounts for things like hospital stays, time lost from work, things like that. So that's why we care about cardiovascular disease. Another way to kind of look at this is COVID-19 versus CVD. So since COVID has started, this is data from as recently as yesterday, there's been 677,000 deaths attributable to COVID-19. And so keep in mind that COVID started last March, so about a year and a half. And then the most recent data from 2019 suggests that cardiovascular disease is attributable to 659,000 deaths. So we all know the past year and a half how bad COVID has sucked, and we know that. And that's been a year and a half. So in just 1 year, we have a similar amount of death from cardiovascular disease, things like heart attack, cardiac arrest, and then as we mentioned, stroke. So hypertension is the leading risk factor for cardiovascular disease. And so what we're looking at in this graph is age on the x-axis. So as we go further along to the right, we're looking at advancing age and then prevalence in the population on the y-axis. And so what we can see is that there's an age-related increase in hypertension prevalence. Another thing to keep in mind here is that these are data from 2013. So in 2017, the American Heart Association and the American College of Cardiology reclassified what it meant to have hypertension. So there's systolic blood pressure, whereas it used to be 140 to be classified as having hypertension, that was reduced to 130 to have stage 1 hypertension. So more people actually have hypertension based on the newer criteria than what we're seeing here in terms of the percentage, but the age-related increase kind of still holds true. All right, so next we'll start talking about dietary sodium. So people are probably in a little post-lunch lag, so a little pun here. He threw sodium chloride at me, that's a salt. So a little joke. Okay, but in terms of dietary sodium and what we know and how that affects blood pressure, this is data from a cohort called PEER. So over 100,000 adults from several different countries. And so in this study, they've estimated urinary sodium excretion. So with sodium, basically, if you consume more, you urinate more sodium out. So it's not perfectly regulated, but more sodium you eat, the more sodium you urinate. And so they've estimated urinary sodium excretion here on the x-axis. And what you can appreciate is that with the greater amount of sodium, there's this kind of linear relation, but there's an increase in blood pressure. So here from their slopes, they found that for every 1 gram increase in dietary sodium, there's a 2.1 millimeter of mercury increase in blood pressure. And so these data are also adjusted for things like age, sex, BMI, education, and geographical region. As I mentioned, this is data from several different countries. In terms of how much sodium we consume here in the United States, this is data from Hew et al. In 2020. So the more recent data that they collected kind of ended on 2018. So pretty recent. And so what we can see here is that the average American consumes about 3,400 to 3,500 milligrams per day. So there is a sex difference because men tend to eat more calories. They consume closer to about 4,000. Whereas women consume closer to about 3,000. So it averages out to about 3,400 to 3,500 milligrams of sodium per day. And that far exceeds the recommended level of sodium. So we can see the dietary guidelines for Americans. So that's the Department of Health and Human Services, is about 2,300 milligrams per day. And then we consume over twice the amount that's recommended as optimal by the American Heart Association, of about 1,500 milligrams per day. In terms of what that means for cardiovascular disease risk, in this analysis of several studies, basically what was found was that if you consume about 4,000 milligrams per day, so again, remember that's about average for an average American man, is associated with a 17% increased risk of cardiovascular disease. Okay, so I think this is a kind of cool data that I'll present next year. It's an ethnographic study. So they studied a tribe or society called the Yanomami Society in Venezuela. And they compared them to a group called the Iguana. So the Iguana and the Yanomami both are fairly remote, kind of not living a modern lifestyle or Western lifestyle, but the Iguana group participates in trade. So they consume more processed foods, more high sodium foods. And so it's not a perfect study because you can't isolate the effects that we'll see here to just sodium. It's kind of more of a society that eats processed foods versus a society that does not eat processed foods. But a major component of that is the dietary sodium intake. And so what's cool about this is we can see if blood pressure really does inevitably rise with age. So that slide we saw a few slides ago where we showed on the x-axis age and how hypertension goes up with age. That's what researchers from Hopkins sought to assess here. And so what we can see is that in the Iguana individuals, on the x-axis here, we have individuals anywhere from kind of toddlers to 60 years old. There's this age-related increase in blood pressure, not quite as steep as you would see in a Western society. However, in the Yanomami society, where they consume very, very little sodium, it's the same thing, toddlers to 60 years old, there's a flat relationship here between age and systolic blood pressure, suggesting that things in our modern diet or modern lifestyle are causing that increase in blood pressure with age, as opposed to something that's just naturally that occurs in everybody. And that same trend was revealed for diastolic blood pressure as well. So you can see in the Iguana, that age-related increase, and then it's just kind of flat despite age in the Yanomami society. So apart from blood pressure, we also know that there are cardiovascular effects of dietary sodium as well. So these are data from the trials of hypertension prevention 1 and 2. So these are two separate trials that took place in the late 80s, early 90s. And so in the sodium intervention group, or the blue lines, so that's the sodium intervention group, participants were counseled to reduce sodium, and they underwent intensive education. So they had dietitians and nurses work with patients or participants to reduce their dietary sodium intake, kind of coaching them on what foods to eat to reduce their sodium. And then there was a standard control group as well on the red hashed line here. And so what we can see on the y-axis is cumulative incidence of cardiovascular disease. And then for both of these studies, they're really large studies. They brought people back in years after their initial examination. And so what we can see is that there's separation, where the sodium intervention group has a lower cumulative incidence of cardiovascular disease, more so in TOHP1 and TOHP2, but in both cohorts, there's a reduction in cardiovascular disease compared to the control. And so with the CVD events, the main outcomes were cardiovascular disease, myocardial infarction, stroke, and death. So, so in terms of where is most of the dietary sodium in the United States coming from, these 6 foods that we'll describe here make up about 40% of the dietary sodium that most Americans consume. So you can see breads and rolls, poultry, sandwiches, which contain a combination of both bread and lunch meats, poultry. Pizza is on that list, another kind of multi-ingredient food here. Dietary soup, or not dietary, sorry, condensed soups have a lot of dietary sodium, and then cured cold cuts, cured meats. So then I just wanted to show some kind of real-world examples of foods that are high in sodium. So again, the recommendation is 2,300 milligrams per day. So if you look at like 3 slices of Papa John's pepperoni pizza, that puts you back about 2,700 milligrams. An Italian BMT from Subway is about 1,100. Campbell's chunky chicken noodle soup is about 1,700 milligrams in a can. Chipotle steak burrito is about 2,200. And then I always give a shout out to a former grad student, Alex Barnett, 'cause his favorite was the Waffle House All-Star, and that would push back about 2,200 milligrams. So he'd always joke that he was taking me to Waffle House, but I just didn't want to go with him. So, but in terms of processed foods, again, that makes up the vast majority of our sodium intake in America. So it's really hard to reduce your sodium without kind of really changing the foods that you eat. So this is data from, I believe it was 2017, where they looked at sodium intake across several sites in the United States. And what they found was that processed food makes up about 70% of our sodium intake, whereas what you add at the table, if you use a salt shaker, only really accounts for about 6%. So it's not like most people are just pouring a ton of salt on their food. It's mostly from processed food. So it makes it really difficult to reduce your dietary sodium. And then in terms of what we'll focus on in the next several slides, with the blood pressure independent effects of sodium, like I mentioned earlier, we'll focus on vascular dysfunction and renal dysfunction and sodium handling. Okay, so blood pressure independent effects of sodium. So what I mean by this is that in the population, there's a lot of variability here, but for the most part, if you took a group of healthy young adults and put them on a high sodium diet, only about 25% of them would actually experience an increase in their resting blood pressure. So that would change in certain populations. So if you did that same study where the age range was 60 to 80, you'd see a lot more salt sensitivity, but in your general population, mostly healthy young adults, there's not a ton of salt sensitivity in terms of resting blood pressure. But there does appear to be effects on the endothelium and kidney function, which could then later contribute to salt sensitivity or cardiovascular disease down the road. So vascular function, we'll specifically focus on endothelial function here. So we have a cross section of an artery. There's three kind of main layers here: the tunica adventitia, the outermost layer, tunica media, or the vascular smooth muscle cell layer, which controls vascular tone. And then the innermost lining, which we focus on here, is the endothelium, which releases vasoactive compounds like nitric oxide, and that kind of regulates the vascular smooth muscle cells and blood pressure regulation. So normally what happens is with blood flow, there's an increase in shear stress against the arterial wall, and that causes a release of nitric oxide, resulting in the vascular smooth muscle cells relaxing, and that causes vasodilation for the blood vessel to kind of relax and vasodilate. And so first we'll focus on a technique that we use to assess large artery function, and that technique is called flow-mediated dilation. So we specifically image the brachial artery. And here you can see one of the grad students is imaging the brachial artery in the participant's upper arm. And then we can see on ultrasound this kind of 2D image of the brachial artery here. And so the reason that we are interested in this particular measure is that it's correlated with cardiovascular risk. So for every 1% improvement in FMD, there's a 9% reduction in cardiovascular disease risk. So it's been shown in several cohorts to correlate with future cardiovascular disease risk. So this is what we would see if we kind of zoomed in on that monitor. So we see the vessel diameter. So you're tracking the walls of the arteries. You have the upper wall and the lower wall here. And then we also track blood flow velocity. So when you know the blood vessel's diameter and the blood flow velocity, you can calculate blood flow. So let me actually go back one slide here. One thing I forgot to mention is on the participant's forearm, so the image extended out here, we have a cuff, so you can see the cuff here. Basically, what happens is we get a 1 minute resting baseline image, so we capture video in real time of the brachial artery diameter and blood flow, and then we inflate that cuff on the forearm for 5 minutes, and that cuts off blood flow, so we would see a reduction in the blood flow velocity. And then we would release the pressure in that cuff after 5 minutes and continue to record for an additional 3 minutes. And that's when you see the blood vessel dilation. So that's why it's called flow-mediated dilation. So you go from having the cuff inflated, kind of reduces blood flow because you have a ton of pressure on the forearm. And then once you release that pressure, there's a large increase in blood flow. And that should cause the blood vessel to dilate if the person's healthy. So that's, again, what we see kind of on our end, so diameter, blood flow velocity, this would be representative of what we would see just during rest, that 60-second baseline. And then this is what we would see after we release that pressure cuff. So you can see compared to the image on the left, there's this large increase in blood flow velocity, and that's the stimulus that causes the blood vessel to dilate. So next I'll present some data from my postdoc mentor's lab. This was actually collected before I had arrived in the lab, but it's a controlled feeding study where they gave participants a really low sodium diet for 7 days and a really high sodium diet for 7 days. Everything else was matched. So things like potassium, fiber, macronutrients, all of that was matched. So you can really isolate the effects of dietary sodium. So what are we looking at here? Urinary sodium excretion on the y-axis, and then you can see on the low sodium diet and the high sodium diet. So as I mentioned earlier, again, consume more sodium, you would expect to see an increase in sodium excretion. That's exactly what they found. So a regular recommended sodium diet would be about 2,300 milligrams, and so that corresponds to 100 millimolars. And in this diet, they gave participants closer to 7 grams or 7,000 milligrams per day. So you can see that's around 300 millimolar. And then the low sodium diet was only about 500 milligrams, so it's well below 50 millimolar. So there's this huge difference in sodium excretion, as you'd expect. And then in terms of blood pressure, these participants were what we would classify as salt resistant. So what you can appreciate from this graph is their 24-hour mean arterial pressure did not change. So it's the same. So then we classified them as salt resistant because their blood pressure didn't change. If it had, so let's say it went up to here, that would be a salt sensitive cohort. So again, these are these changes that you'll see occurred despite no change in resting blood pressure. So this is the data from the brachial artery flow mediated dilation. So we're looking at the individual data on high sodium and low sodium. And then when we look at the group average data, when we take the average of these individual points, we can see that there's a significant reduction in endothelium dependent dilation after 7 days of high sodium. So next we'll focus on findings using small arteries or resistance arteries and the effects of dietary sodium. And so this setup is a vasodilator setup or a vasodilator prep. And this is something that I did a lot during my PhD. So what we've done here is we've taken a gluteal adipose biopsy. So basically from the gluteal fat pad, we would have a nurse take out a small amount of fat, about 100 or 200 milligrams after she made an incision. And then we would take that back to the lab and isolate resistance arteries. So that's what we're looking at here. We've cannulated a small resistance vessel. So we basically put both ends of it on glass micro electrode or glass micro pipettes here. And that's what you can see here. And then you tie the vessel in place with nylon filaments. So you kind of tied it in place and pull back to keep it at a normal physiological length. So you don't want to like pull it too tight or anything and stress out the vessel, but you cannulate it and try to create an environment that's similar to what it would experience in your body or in vivo. So we put it in an organ chamber, which we keep at 37 degrees Celsius, so close to physiological concentration, and then we provide oxygen, and also it's bathed in a physiological saline solution in this organ chamber. So at rest, we have 2 of these reservoirs at 60 centimeters of water, which is about 40 millimeters of mercury. So that's physiological pressure that a resistance artery would experience. And then we can assess endothelial function in these vessels using different pharmacological agonists, such as acetylcholine. So acetylcholine results in nitric oxide production, which causes that blood vessel to dilate. Or we can mimic what happens in the body and change the height of these reservoirs to create a pressure gradient, which causes flow throughout that resistance artery, and this ex vivo prep. So by creating this pressure gradient here, you create flow through the artery, and it should dilate in response to that. Okay, so next I'll present some findings using that same technique with dietary sodium. So what we can see on the x-axis here is the change in the pressure gradient. So 10 centimeters of water up to 100 centimeters of water, which would be a pretty high pressure gradient, should cause an increase in vasodilation, and that's what we can see. So what we see on the y-axis is percent vasodilation. So we initially pre-constrict these vessels. We had a compound called ET1, which caused them to pre-constrict, and then we expose them to those flow gradients, and then it should dilate. So the next thing that we would do is add a compound called L-name, which inhibits the production of nitric oxide. And so as you would expect, when you add L-name and inhibit the production of nitric oxide, there's a reduction in flow-induced dilation. So you can see each of these bars is much lower than corresponding unmarked bars. And then these participants received a dietary sodium supplement or a control. And so under the high sodium diet, you can see that there's a reduction in flow-induced dilation compared to the same pressure gradients under the normal sodium or habitual sodium diet, and that there was less of an effect of L-name. So what these data suggest is that a high sodium diet reduces nitric oxide bioavailability. So during my postdoc, we wanted to determine whether sodium loading would influence endothelial function and also exercise blood pressure responses. So there are prior data suggesting that impaired endothelial function, or if your blood vessels can't dilate as well, that you're more likely to have larger increases in blood pressure during exercise. And so for this particular study, we recruited healthy young adults, 18 to 40 years old, who had non-hypertensive blood pressures and were recreationally active. So no elite athletes, but people who exercised a few days. So then there was screening, VO2 peak test, and then we had them cross over two different protocols. So they received capsules containing sodium chloride, 3,900 milligrams of sodium on top of their diet. So we counsel them to consume a standard, or not a standard, but a recommended sodium diet, so 2,300 milligrams plus the 3,900 milligrams that they were receiving in the capsules. And then they would cross over into a placebo capsule study. So instead of taking sodium, they would take placebo, or if they took placebo first, they would then take sodium capsules. And so the goal was for them to consume 6,200 milligrams of sodium on the high sodium, and then 2,300 milligrams when they took the placebo. And so that's actually me when we were doing some of our pilot testing, the B2B finger pressure cuff here on. And so we would measure blood pressure at rest, and then we would have participants ride a bike for 60 minutes. So there's a 5-minute warm up, 50 minutes riding at 60% of the maximum intensity that they obtained when they did their VO2 peak testing, and then a 5-minute cool down. And we would assess blood pressure. And the reason we were interested in these blood pressure responses is because there are data suggesting that the blood pressure responses to different stressors, including exercise, are predictive of future hypertension incidents. So in this study, from Miera et al., what we're looking at is time after the exercise test on the x-axis. So they tracked participants up to 7 years, and then they broke them into quartiles based on their blood pressure responses during the bout of exercise. So in the first quartile, for example, these are the people who kind of that bottom 25th percentile, so they had a pretty modest exercise blood pressure response. And then in the fourth quartile, it would be someone who had a really large blood pressure response during exercise. So for example, someone whose systolic blood pressure went up to like 190 to 200 millimeters of mercury. So what you can see is that the fourth quartile had the greatest cumulative incidence of hypertension as they followed them up over the years, compared to the first quartile, second quartile, third quartile. And so basically what that means is that you can use different physical stressors like cold or exercise to kind of predict who's going to have hypertension a few years down the road. So while your body's kind of keeping things under control at rest, if you have these exaggerated responses to stress, that kind of early sign you have blood pressure dysregulation. So that's why we were interested in that, because in a lot of these cohorts who aren't salt sensitive, it shows that maybe there's still some underlying blood pressure dysregulation that's occurring. So these are participant characteristics. You can see that pretty healthy cohort, 20 adults, about 24 years old on average. BMI was below that 25 cutoff. VO2 peak was about 40. So again, these are recreationally active adults. And then when we look at blood pressure, we can see it's 110/64. So on average, pretty healthy blood pressure as well. And then these are our data from the exercise blood pressure that I mentioned. So again, that 5-minute warm up, we have 50 minutes of exercise and a 5-minute cool down. And what you can see is that there was a significant difference in systolic blood pressure with the salt loading compared to the dextrose condition. So that's just our placebo. So with salt loading, there was an exaggerated systolic blood pressure response, which you can also see here as well. However, there was no significant difference when we looked at mean arterial pressure or diastolic pressure. So most of this, again, seemed to come from systolic pressure. So we thought maybe one of the factors that could contribute to this could be an increase in cardiac output. So as I've mentioned a few times, when you take in more sodium, you're going to urinate more of that out, but it's not a perfect match. So one of the things that your body can do to kind of compensate if you have more sodium in the bloodstream is to increase your plasma volume. So basically have an expansion of blood volume, and that results in an increase in cardiac output. And we think that's why our findings were specific to systolic blood pressure. Just kind of speculation, but that's what. In terms of endothelial function, so similar to the previous data that was collected in my postdoc mentor's lab, we also found that there was a reduction in brachial artery flow mediated dilation with salt loading. And interestingly, we did find that the greater the reduction in FMD, so the further you go to the left here, the greater the increase there was in systolic blood pressure with the sodium loading compared to the dextrose or placebo. So again, that's just indicating that maybe this decrease in endothelial function is contributing to that increase in systolic blood pressure that we saw with sodium. So we'll transition to renal function next, just kind of a summary slide on endothelial function and sodium. So this is a review paper that was written last year, or earlier this year actually, from Jordan Paddock, who's a current postdoc at the University of Delaware. He summarized about 20 different studies that have looked at endothelial function in humans with salt loading, and all but one of them have found a significant reduction in endothelial function. So it's pretty well documented now. Some of the mechanisms include an increase in the expression of NADPH oxidase, so that's a pro-oxidant enzyme within the vasculature, or a decreased expression of superoxide dismutase, which is an antioxidant enzyme within the vasculature. And then they've also mentioned some of the interesting study from preclinical models with rodents with the glycocalyx, which is basically kind of this glycoprotein structure on our cell membranes that senses increases in shear stress. And so if that becomes disrupted, that could be one reason why the blood vessels are less responsive to an increase in blood flow. So if you're interested, I would highly recommend checking that paper out. And next, we'll focus a little bit more on kidney function. Okay, so salt and kidney function, we know from multiple different cohorts that high dietary sodium intake is linked to future incident chronic kidney disease. And so there's a few different mechanisms how this could kind of result. One might be an increase in arterial stiffening. So if you have greater flow pulsatility to your target organ, such as the kidney, that could lead to kidney injury and a reduction in kidney function over time. And then there's kind of a growing interest in biomarkers of kidney injury that you could measure in the blood or in the urine that have been shown to have predictive value for future kidney disease. And so two of them that we'll focus on here are NGAL, or neutrophil gelatinase associated lipocalin, and then the other one is kidney injury marker 1, or KIM1. All right, so in terms of the two biomarkers that we're focusing on here today, NGAL has been associated with CKD progression and severity. NGAL has also been associated with incident CKD in stage 3 CKD, specifically in ERIC, so that's a large cohort study. And then KIM1 has been associated with incident CKD in MESA, so that's another large study, the multi-ethnic study of atherosclerosis. So that's multiple large cohorts have shown that there seems to be a relation between these particular biomarkers and future kidney disease. So that's why we're interested in these particular biomarkers, but there are several that you could mention. So like I mentioned, we're focused more on these two markers that are indicative of proximal and distal tubule injury, but there are several others that you could measure, including IL-18, UMOD, MCP1. And you typically measure these analytes using immunoabsorbent assays or ELISAs that you can assess urine sample. So that's kind of one of the reasons that we're also interested in them. They're sensitive biomarkers that you can measure in the sample. So there are previous rodent data suggesting that sodium does cause an increase in these AKI or acute kidney injury markers. So in this particular study, it's from Whistler coyote rats, and they're looking at 8 weeks of data. So starting at week 9, the rats consumed these different levels of dietary sodium and followed them up in week 17. And then you look at a urinary NGAL being expressed here on the y-axis. And so what we can see is with 8% sodium chloride, which is a really high sodium diet for these rodents, there's an increase in NGAL starting after about a week of the high sodium diet. And so what's interesting about these data are that under the same conditions, there's no change in serum creatinine. So if there was a change in serum creatinine, basically indicate that the kidneys weren't filtering out protein to the same extent. So it seems like there's not this increase in protein concentration within the serum. And then when we look at urinary albumin, which could indicate proteinuria, there's no change here. So it suggests that that change in NGAL is happening well before you would see like an actual reduction in kidney function. And then there's also recent human data that came out last year in older adults. So for this study, they used 5 weeks of dietary sodium restriction. So participants consumed a habitual diet, and then for 5 weeks they were instructed to consume a lower sodium diet. That's in 13 older adults. And then really like this study design because they use a 24-hour sodium collection. So that's kind of the gold standard. Some studies will just use one spot sample where they have participants come in and urinate and then do all their testing in that one spot sample. Whereas in this study, they collected for 24 hours, similar to some of the data that I presented from our group earlier. And so what they found was that there was a 31% reduction in NGAL. So this is data from the normal sodium condition and the low sodium condition. And you can see that their normal sodium intake was about 150 millimolars. So that's a little over 3,000, 3,200 milligrams. So about what you would expect for standard Americans. And then also consider that these are older adults. So they probably ate a little less. And then once they underwent sodium restriction, you can see it's a little under about 2,000 milligrams per day. So they did a pretty good job with the sodium restriction. And these changes occurred despite no change in creatinine excretion, so no change in glomerular filtration rate. And KIM1, the other analyte that we said we were interested in, wasn't measurable in samples. So this is, again, just kind of a reminder using that same study design that I mentioned a few slides ago, where we looked at exercise blood pressure responses and endothelial function. So when we assessed NGAL in the plasma, there's no change. However, when we assessed NGAL in the urine and indexed it to flow rate, so basically what you do with this flow rate is, let's say you collect 2 different samples. If someone was kind of dehydrated one day and they only urinated like, say, 800 milliliters, so a pretty small amount, they would have higher concentration compared to if that same person came in and they were super hydrated. So you want to index to the volume of urine that was collected as well. And so what we can see is when we index to that, there's a significant increase with dietary sodium intake. And then when we index the NGAL to creatinine, there was no change. And I'll kind of explain what we think happened there in a couple of slides. With KIM1, there was no change in either the plasma or the urine samples when we indexed flow rate, and there was no change when we indexed it to creatinine. So other renal data, urinary sodium or urinary creatinine excretion was significantly increased with sodium. And so we think that's why there was no change in NGAL when we indexed to creatinine. So normally you would expect creatinine to be pretty constant. However, there are several studies that have shown that if you put participants under a really high sodium diet, you can increase their glomerular filtration or increase urinary sodium excretion. And so that actually is what happened in our study. You can see there was an increase there. And so when we calculated creatinine clearance, which is a measure that's based on both urine creatinine and serum creatinine, there's a significant increase in the unadjusted creatinine clearance. And then when we adjusted creatinine clearance for the participant's body surface area, there's still a significant increase. And then we kind of went back and double checked and measured another marker, so cystatin C. So that's even thought to be kind of more constant than creatinine. It's released at a constant rate by all of our cells. And that was also increased with high sodium. So between both of those measures being increased, we do think that there was a real increase in glomerular filtration rate. And so I've kind of brought up this glomerular hyperfiltration, or this increase in glomerular filtration here. And the reason that's important is because over time, glomerular filtration is also an independent predictor of cardiovascular events. So that kind of aligns with our prior data suggesting that despite no change in resting blood pressure, that increase in dietary sodium does seem to have some negative effects on our physiology. To summarize, high dietary sodium is linked with future incidence of chronic kidney disease, increased glomerular filtration rate in our cohort of healthy young adults. It also increased expression of the kidney injury marker NGAL, and that these data would suggest that over time, if participants continued to consume a very high sodium diet, that would increase their risk for future CKD and kidney damage. All right. So next, I'll kind of pivot to some of our work on racial differences on the effects of sodium. All right, so as I mentioned earlier, there's differences in salt sensitivity. So you would expect an older cohort, for example, to be more salt sensitive compared to a younger cohort. Or you would expect an unhealthy cohort to be more salt sensitive compared to a cohort who is really active and healthy. And one particular subgroup of our population that has been shown to have increase in salt sensitivity are African Americans. And so we've been interested in trying to figure out why that is from multiple different angles. So this is data that we published 3 years ago in a cohort of healthy young adults, white and black individuals. And so what we can see is serum sodium on the x-axis here. And so for this study, what we use is called a hypertonic saline infusion. So you basically place an intracubital intravenous catheter, and you can infuse what's called hypertonic saline. So it's saline with a higher sodium concentration than our blood, and you can use that to increase sodium concentration in the blood. And so on the y-axis, we're looking at systolic blood pressure, and the two groups were pretty closely matched at baseline, and they just came in under normal conditions. And then once we started that hypertonic saline infusion, sees that there's a greater slope. So in the black individuals, they had a greater change in systolic blood pressure for a given serum sodium value. To look at that data another way, when we broke it up categorically, we looked at changes of serum sodium, 0 to 3 millimolar, 3 to 5 millimolar, or what we considered a large change of greater than 5 millimolar. And there's a significant group effect. So there's kind of a trend here for that any given increase, there's larger increase in systolic blood pressure in the healthy young black individuals compared to the white individuals. And then we also think that there may have been something there in terms of being able to buffer that change in serum sodium. Something happening with the kidney where you can't kind of excrete more of that sodium rapidly. And so the reason we thought that is when we looked at the change, so 0 to 3, a pretty modest change, 3 to 5, what we consider moderate, 5 plus, we can see with the Fisher's-Zack test is that there was a greater proportion, or a trend for a greater proportion of these kind of large changes in serum sodium in black individuals compared to white individuals. Only about a third of them experienced that large increase in serum sodium. And so what we're working on now in the lab, a project that Meryl's actually helping out with quite a bit, is a study on acute sodium loading. So we're giving individuals a really high sodium meal, about 2,500 milligrams, and we were taking measures before and after that high sodium meal. As I mentioned earlier, kind of way back in terms of some of the sodium contents in common foods, 2,500 milligrams is a lot, but there are meals that you can get out there that are closer to 3,000. So if you went to like Applebee's or something like that, you got an entree and an appetizer, people consume 3,000 milligrams in one sitting all the time. So that's one of the things that we really like about this study is that we're using a load that people would attain in any given day. But anyways, we're screening participants, taking them through a VO2 peak test, and then we have them come in on 2 separate occasions. On one, they consume a low sodium soup meal, and on the other, they consume a high sodium soup meal. And when I was a postdoc, we did a study focused on high sodium and cerebrovascular function. There was no racial disparity component to that, but what we did find was that there were significant increases in serum sodium. And so basically what we're trying to do with this study is try to keep that hypertonic saline study that we did earlier, kind of moving that along, but using a more physiological model, because in the real world, we don't infuse hypertonic saline, but people do eat high sodium meals all the time. So in terms of racial differences in salt sensitivity and what's out there, one of the kind of popular hypotheses that I really wish would just go away is the slavery hypertension hypothesis. I think it was 2007 where Oprah and Dr. Oz even discussed it on her show. So it's kind of mainstream. It's something that's kind of broken into the mainstream. There's a few papers on it. So it's got a couple different names. You can see here the African gene theory or slavery hypertension hypothesis. And it's something, again, that I really like to see go away just because it's not really founded on data. It's just people kind of speculating or theorizing. But basically, this is kind of, I want to say 70s, 80s, early investigators hypothesized that there was a genetic difference in Black individuals to retain more sodium that had to do with ancestry and the transatlantic slave trade. So there's kind of three components to this hypothesis, or to these hypotheses. One would be the hot and arid environment in Africa. So different historians have kind of gone back and said, no, that doesn't really check out. So the initial thought was, okay, so if you're in a hot and arid environment, you have limited access to sodium, that's going to cause selection pressure to maintain sodium, especially like in a condition like now, like where we have tons of sodium available to us. But basically, the historians have kind of pointed out that there were several trade routes. So there were several trade routes that individuals in West Africa could have obtained sodium through, and then also just being on the coast, there's different salt baths where they could have dried out sodium that was just in the water. And so it doesn't seem like having a limited amount of sodium historically would contribute to that. The other kind of tenet to this was the transatlantic slave trade. So there was thought that on that kind of transatlantic voyage, that limited access to food and potable water and sodium would have been a selection pressure as well. However, you know, obviously the conditions on these slave ships would have been terrible, but you don't want to pick up a bunch of people in Africa and bring them to America and then have half of the ship die. So while individuals were treated terribly, there is evidence to suggest that they were fed, they were provided sodium. So they wanted to keep them alive, not for ethical reasons, but for financial reasons. So that doesn't really check out. And then New World slavery, again, hot and arid environment, less than adequate nutrition was thought to be maybe another selection pressure. But if you go back, historical record shows that most of the deaths from New World slaves would have been more attributed to like pulmonary diseases and things like that, where your immune system's not acclimated to this new environment. And so that was more of a major cause of death than things like dysentery or electrolyte imbalances. And then there's actual data to suggest that this also isn't the case either. So these are data from Curtis Morris's group at UCSF. He's done a lot of work in terms of salt sensitivity in African-American cohorts. And so what we can see here is change in sodium balance, accumulated sodium balance on the y-axis here, and body weight change. So if your body was holding on to more sodium, again, you would hold on to more water too, you would gain more weight. But what his group has found, if you compare salt-sensitive individuals and salt-resistant individuals, anything, the salt-resistant group here had a greater change in body weight and a greater change in cumulative sodium balance. So that would suggest that retaining more sodium is not like a leading driver of salt sensitivity. And then additional data from their group, when they looked at changes in mean arterial pressure, as you expect, salt sensitive group by definition is a larger change in blood pressure. But when you kind of look at what's really driving this, you see things like changes in renal blood flow. So there could be an increase in vasoconstriction to the kidney. And then you look at changes in things like renal vascular resistance. You can also see that's greater too. So it appears that most of this change in pressure is mediated by renal vascular dysfunction of the kidney. Another kind of major driver of changes particularly in people who have African ancestry. Could just be urbanization. So this is a study that was done in Kenya. And so they looked at pre-migration and post-migration data, systolic blood pressure, diastolic blood pressure, things like body weight. So what you can see is there's a significant increase post-migration. So if you went from more of an agrarian lifestyle to living in an urban environment, there's an increase in blood pressure, but also a change in body weight. And you can see this huge increase in urinary sodium excretion. So that would indicate that the participants in this study were eating more processed foods and more dietary stuff. Other data suggesting that there's not something unique about African ancestry or hypertension prevalences from around the world. So what we can see here is that in the United States, Black individuals have among the highest hypertension prevalence in the world. But if we look at Nigeria, for example, which is a West African country, or Jamaica, where there's a lot of West African ancestry, the hypertension prevalence isn't nearly as high as it is here in the United States. However, again, in the United States, we do have a problem. So consistently across different cohorts and different time spans, you can see that there's a consistent racial disparity where Black adults tend to have the highest blood pressure for both males and females compared to non-Hispanic white adults or Latin adults. And so, well, one of the things that is kind of true is a lot of the Black individuals here in the United States do have West African ancestry. It doesn't appear that that's a predictor of blood pressure either. So there's recent data from the SPRINT trial where they looked at composite cardiovascular events, so things like heart attack, stroke, cardiac arrest, and mortality. And what they looked at was African ancestry on the x-axis here and hazard ratio of the primary composite outcomes. And you can see that if anything, there was a slightly inverse relationship. And so again, this is from the SPRINT trial. So that's a fairly recent trial. A lot of the big results from that were published in 2015 through 2017. One of the trials that kind of informed the new blood pressure guidelines. All right, so social determinants, that's kind of one of the things that we're interested in the lab now. We're collaborating with someone, Thomas Fuller-Rao, who's a faculty member at Auburn in Human Development and Family Studies. And so some of the things that we can look at that might contribute to racial disparities, one of them could be redlining. So this is an excellent book I would recommend anyone read. It's by Richard Rothstein, he's a historian and a lawyer out of Yale. And he talks about redlining. So this is basically back in the 40s, 50s, up to the 60s, different neighborhoods wouldn't allow Black families to live there based on where these neighborhoods were at in the cities. So you can see like here they've kind of outlined what would be a red line neighborhood. So this would be a neighborhood that was disinvested where they would kind of push Black families towards compared to white families. And so redlining and lack of home ownership and things like that throughout the middle 20th century is thought to contribute to some of the things that we see now. So if we look at like the majority white community compared to majority Black community, and we look at median household income, you can see that there are large differences here. And then if we look at home ownership rates, again, we can see a large difference between majority white and majority Black communities. So that's kind of intergenerational wealth that you kind of missed out on if you were a Black family in the 40s and 50s, as home value appreciated, and you can pass that down to your kids and grandkids and things like that. So definitely a socioeconomic status component. Sleep is another major factor that may contribute to racial disparities. So I mentioned the MESA study earlier, this large study of over 6,800 adults. In 2012 to 2015, there's a MESA sleep called an ancillary study. So in about 2,000 of those adults, they measured sleep, and there's about a 40-minute difference per night where Black folks tended to sleep least. And so they've consistently been shown to have worse sleep continuity and duration. So continuity is just an index of sleep being interrupted and kind of more relaxing. Duration is just how long you sleep. Vitamin D, so this is recent data from our lab. We're measuring M index, so the melanin index, and how that relates to vitamin D. And so the reason that we care about that, so we can see also that there's a racial difference in vitamin D in the blood, and that there's a greater prevalence of vitamin D deficiency, or less than 20 nanograms per ml here in Black folks. And so the reason we care about vitamin D Vitamin D is thought to kind of regulate nitric oxide bioavailability. So we talked about nitric oxide and vasodilation earlier. So you have an increase in melanin that can inhibit vitamin D synthesis. And through the vitamin D receptor, that plays a role in NADPH oxidase expression. So that's a pro-oxidant enzyme, superoxide dismutase, that antioxidant enzyme, and actually directly plays a role in regulating eNOS, enzyme that produces nitric oxide. So the thought is that perhaps an increase in melanin leading to a decreased vitamin D could contribute to a reduction in vascular function through nitric oxide. All right, and then lastly, we'll talk a little bit about diet. So a common misconception is that there's a difference in sodium intake, actually, where a lot of people tend to think that African Americans consume more sodium. However, that doesn't appear to be the case, but what does appear to be the case is intake and background diet. So there are studies showing that what you consume in addition to sodium or outside of sodium plays a large role in how that affects your body. And so there are racial disparities in things like fruit and vegetable intake, where Latino populations and Black populations tend to consume less, and that kind of goes away after you adjust for socioeconomic status. So again, yeah, there's more of this background diet. We're consuming more nutrient poor but energy dense foods, more processed foods, and that could just be a matter of availability in many cases, where if you have less access to healthy foods or more access to like corner stores and things like that, where you can have a diet that's a little bit less high in quality compared to others who have more availability. I mentioned sodium intake being similar across different races and ethnicities. And then one important factor may be dietary potassium. So I mentioned earlier, Curtis Morris and his group have done a lot of work with salt sensitivity and racial disparities. And so in this recent review paper, they summarized several studies that looked at racial comparisons, changes in mean arterial pressure with high sodium. And you can see the black bars are meant to represent cohorts of primarily Black individuals compared to cohorts of primarily white individuals. And there's a trend for there to typically be a large racial disparity here. However, in the few studies that have also given high potassium intake, that seems to completely attenuate that racial difference in salt sensitivity. So there are 3 studies that have given potassium concentrations of greater than 87 millimolars, which is the USDA recommendation. And in those studies, it seems like the racial disparity in salt sensitivity is attenuated. So in terms of our future directions and additional goals in the lab, again, we want to keep focusing on social and lifestyle determinants. So we're doing a lot of work with, as I mentioned, Tom Fuller-Ralph. He's looking at things like neighborhood disadvantage across the lifespan in some of his participants, and then we're bringing them into our lab for additional studies of vascular function. We measure actigraphy, physical activity, cardiorespiratory fitness, different questionnaires related to mental health and well-being and sleep. And then we're also interested in factors that we can use to try to mitigate sodium chlorides, things like dietary nitrate, which is really high in fruits and vegetables, and different nutraceuticals that might kind of counteract the negative effects of sodium, since so many people have a hard time reducing their sodium intake. So with that, I just want to acknowledge different collaborators that I had in the postdoc in Delaware, here at Auburn and UAB, funding mechanisms, and I want to thank you all for taking time on your
Interesting, you know, thank you so much. Now I just want to open it up. If you have to leave, I totally understand. Thank you for coming. But if you have any questions for Austin, you do need to do so quietly. If you have any questions for Austin, I'm sure he'd love to entertain them. I guess I can start it off.
Yeah, I was just curious, given everything that we know about sodium influence on cardiovascular stuff, have you made any personal lifestyle choices? Like sodium intake?
Yeah, when I was a kid, actually, my blood pressure was creeping up, like even when I was like 8 or 9. So by the time, I think it was like my 8th grade physical before football, like the doctor was like, whoa, you know, this kid has full-blown hypertension. So I was on an ACE inhibitor for a while, and then even a loop diuretic. And then after high school, like after senior year, then I'm not going pro or anything. So I just really focused on losing weight, and then did exercise science, as I mentioned. So I took some sports nutrition classes and really focused on changing my diet, doing a lot more cardio. So I would say I probably made a lot of changes before I knew this, but this kind of more reinforced it.
Cool, thank you.
Yeah, question. Did you take into account predispositions to sodium intake?
Like, do we measure how much they normally take in?
No, like the inabilities for individuals to use sodium to the best of its ability in the body versus somebody that has a problem with sodium intake versus people that don't have a problem with sodium intake. I know you've done experiments with different age levels, different ethnicities, and the racial contents, but what about predispositions to that type with research that you're doing?
Yeah, so there are the renin-angiotensin-aldosterone system, so that kind of regulates fluid volume. And there are some studies showing that there might be gene variants within like the RAS or the renin-angiotensin-aldosterone system that might kind of influence sodium sensitivity, but we haven't done any sort of genotyping in our studies. I think it would be cool. But that would be the type of study like multi-center, several different labs, because you would have to kind of do a pre-screen genotyping and then kind of randomize people. And, okay, you're going to take high sodium, you're going to take high sodium plus something that might counteract it. So that'd be a huge study. So we haven't done anything like that first one.
So in addition to kind of like the social determinants you talked about, what are your thoughts on like how systemic inflammation from any of those things, whether it's stress from lifestyle versus food intake, that might correlate with a high sodium diet, how might that play into like the disrupted endothelial dependent dilation, disrupting like nitric oxide bioavailability?
Yeah, no, that's a good question. In terms of inflammation, I did show the data with the resistance arteries and how in our particular group we had used L-name, which blocked nitric oxide production. You can also give things like indomethacin, it's kind of like aspirin, it's a cyclooxygenase inhibitor, and things like that. So I've seen a little bit of that work in isolated blood vessels, but I haven't seen any studies where they've given things like aspirin or something that might inhibit inflammation to determine if that maybe helped with some of the racial disparities. So I haven't seen anything like that. But that's a good question.
Thank you very much for the presentation. You kind of mentioned something at the very end about potassium that I was thinking about the whole time. What I just would like you to elaborate on the role potassium plays. Is this a ratio issue in terms of if we should have an appropriate ratio of potassium to sodium, or just any elaboration on that?
Sure, yeah. So I think that the best elaboration would be a little bit indirect. The largest study that we kind of have for that is the DASH studies, dietary approaches to stop hypertension. And so in that study, a DASH diet, I guess it clarifies higher in fruits and vegetables. It's got a greater amount of low-fat dairy, whole grains. So at least compared to the standard American diet, it's a pretty healthy diet comparatively. So in a large study across different centers, over 400 adults, they had people take high sodium or low sodium with a regular diet or a DASH diet. And the DASH diet did seem to prevent the increase in blood pressure compared to the standard American diet. So it didn't completely stop an increase in blood pressure, but it did seem to reduce it compared to the standard diet. But when you gave a low sodium DASH diet, it did seem to be even better in terms of blood pressure. I guess the major limitation with that study is they didn't follow people up for years and years and years, so it's not clear if they had less cardiovascular disease or anything like that. But purely from a blood pressure standpoint, it did seem that the DASH diet, which one of the major things in that is potassium, seems to be kind of protective. And then some of the studies I cited towards the end there, where they've given people potassium chloride. So in that case, you really are just giving potassium. You're not changing other components of the diet. It does seem to attenuate salt sensitivity a little bit. So I do think the ratio is important for sure. There's a difference between eating a diet that's high in sodium in the context of like eating a ton of burgers and fries and pizza, and then being someone who maybe likes to make meat on the grill and eats a ton of veggies, but then puts a little salt on their food. So that definitely does play a role.
Great presentation. At the beginning, you showed the data showing the increase in the prevalence of hypertension, aging, and then you alluded to how you would anticipate greater salt sensitivity in older adults compared to younger adults. I was just wondering, out of my own personal interest, are you aware of what are suspected to be the leading candidate mechanisms for, and maybe they're biological or maybe they're lifestyle, why older adults may be more salt sensitive than younger adults?
Broadly speaking, I would say they have less physiological reserve. Like if you consider high sodium to be kind of like a lifestyle challenge, I think that just with biological aging, you're probably going to have less of the mechanisms in place to kind of protect yourself or counteract that. Because older adults, just you took older adults on a regular sodium diet, they have reduced endothelial function, they're more likely to have reduced renal function. So one of the major things that salt is doing to increase blood pressure is a reduction in renal blood flow. I think that could be one of the major roles right there.
This may be a silly question, but I'm going to ask it anyway. How do you isolate out all the other complications, stress, and even when you're dealing with a population of young, healthy, non-elite athletes? I mean, I look at my students every day and they're stressed out worse than I am. So, you know, so how do you account for that in your data when you analyze your data?
Yeah, there hasn't been a lot on that really, to be honest with you. Like when in the large cohort studies, they do typically adjust for things like comorbidities or BMI or age. A lot of them don't adjust for any sort of questionnaire related to mental health or depression or stress. That's something that we've started in our lab. So we do have like a state anxiety questionnaire, depression questionnaire. So it's something that we want to be mindful of moving forward, but there's not really a ton out there.
Thank you.
What about adjusting for like baseline blood pressure? If blood pressure is a non-invasive measure of allostatic load or stress or whatever you want to call it.
Yeah, no, that's a good question. It's coming to mind quickly, a study that is kind of tangentially involved with arterial stiffness. So in Dave Edwards' lab, they looked at a change in arterial stiffening with sodium, and they did find across their cohort that there was an increase, but not after you adjusted for mean arterial pressure. So I do think pre-existing hypertension is itself a risk factor for salt sensitivity. So
Thinking from like a more clinical perspective, if somebody was to live like a lifestyle of high salt intake and later in life to make a lifestyle change to kind of decrease that, do you know in terms of health, like for example, vasodilation, is there residual effects, like harmful effects of that long-term salt intake or elevated salt intake? And can that be like restorative through like decreasing intake?
yeah, so I think two parts. I definitely think it would be beneficial to, whether it was exercise or other changes in the diet or sodium restriction. I think as you get older, it's better late than never for sure. In terms of aging and sodium and how that might kind of accumulate over the years, this is kind of more recent, right? So I mentioned increased sodium in, you're going to urinate more sodium, but it's not perfectly matched. So within the past, let's say like 8 years now, there's been groups looking at skin biopsies and then MRI, where they can also look at sodium in the skin. On older adults and hypertensive adults, different patient populations, like individuals with metabolic syndrome, all seem to have an increase in skin sodium content. So non-osmotically active sodium deposition. So it does seem like the sodium is accumulating, and there's some thought that that plays a role in like local kind of micro-inflammatory environments where macrophages can kind of come in and be attracted to the charge of sodium. Yeah, I mean, so I still think it would be better to reduce sodium late rather than never, but it does seem like there is some sort of accumulative damage over the years.
Got one more. From a clinical point of view, did you guys look at using microalbumin creatinine ratio as a marker for early chronic kidney disease instead of just creatinine alone?
No, that's a good question. We didn't. I really just got into the renal measures within the past couple of years. So I
I
expect
know
that.
in the clinical lab, that's what we look at. We look at a microalbumin creatinine ratio at early, and those two together seem to help eliminate a lot of the other
Yeah,
issues.
yeah, no, I think that would be a good one moving forward for sure.
Can I ask a question?
Thank you again, Austin. We really appreciate it.
Thank you.
My
Hold on,
question.
John, I got you.
No, you don't.
Sorry, I was trying not to pay attention to my phone. Austin, one last question for you.
I didn't want to. I'm sorry, Austin. I don't mean to take up your time after all that excellent presentation. By the way, my name's John. I'm an Auburn grad. So I actually have a lot of questions, but I don't want to keep you. So I've been out of the field a little bit of this kind of study for a little while, but I do understand that there's still a lot of investigation about high sodium intake and the effects on the renin-angiotensin system, and that what happens systemically can be different than what's observed locally. And my limited understanding is that locally there can be some augmentation of angiotensin 2, and that may be associated with reactive oxygen species and so on. I'm just wondering is there sort of what do people think about that these days?
Yeah, I think that's a good question. I have seen some stuff with preclinical models, so in rodents where there are changes in angiotensinogen, Ang2, AT1 receptor in the kidney. So if you were to measure it in the blood, everything would just be suppressed. But in the kidney, it seems like there's kind of divergent effects where some of these things are increased, some of them are decreased. So I definitely think there's kind of some divergence between local RAS and systemic RAS. And I think it's really interesting. I don't think there's too much that's known in humans though, just because you can't get like a kidney or anything. I guess the closest you could get would be maybe a muscle biopsy.
And one other question, I'm sorry, because I think you said something about this, but I couldn't hear in terms of mechanisms potentially associated with high sodium intake and endothelial dysfunction. I mean, is there any thinking as to, is there more of a reduction in nitric oxide production, like nitric oxide synthase? I think I heard you say eNOS. Or is it more about maybe degradation due to increases in reactive oxygen species? Is it all the above?
I think it's all the above. So there are some, again, this is rodent data, but they've looked at the aorta and then different like skeletal muscle feed arteries from the hind limbs. And they found, this is Shannon Lennon, who's at University of Delaware, by the way, but her lab found a reduction in NOS, increase in NADPH oxidase, and a decrease in SOD. And then they found that wheel running seemed to prevent a lot of that. So that was kind of cool. The exercise is kind of showing a protective benefit. And then again, it's mostly rodent data, but I'm trying to think, some of the human data where they've done laser Doppler flowmetry, you familiar with that? Where they put the probes on and they do the microdialysis. They have found that there's less of an effective L-name, so it seems like a reduction in NO bioavailability. And then when they infuse like apocyanin or different antioxidants, it seems to help. So again, that kind of seems like it's pointing towards both, like increase in NADPH oxidase, decrease SOD, maybe a decrease in eNOS.
Okay, thanks, man. I really appreciate it. Great talk. Please, when you see Bruce Gladden, give him a hard time.
All right, yeah, he told me that you were at Statesboro because I just took a walk with him the other day.
Yeah, I'm sorry I couldn't be there on campus to see you and to hear your presentation, to be there for your presentation, but I really appreciate the opportunity to tune in, and I hope you enjoy your visit.
Yeah, no worries. It's nice to meet you.
Yeah, you too. Take care. Thanks, Greg.
Thank you, John.
What's this?
Oh, Greg, I'm gonna put you back on.
It's
Bye-bye.
bye-bye.
Bye-bye.